Good afternoon, everyone, and welcome to our latest webinar this month on the Quality Indicators Briefing, our central data. Today we've got a short, sharp session today, a little bit different. We're just doing a quick 30-minute recap of all the big numbers for you today. So we haven't got a lot of time, so we will keep it on scheduled for you today. So we will dive straight into this. But first up, we would like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander people today. So with our agenda today, we will go through our poll results. We always ask you some questions to get some update from the industry and understand how everyone's feeling about these topics. Then we're going to get Tyler, our data insights specialist, to take us through the numbers and the recently released information. We'll hopefully have some time for Q&A. So if you do have some questions, by all means, please let us know and we'll do our best to address those. If not, we can get back to you after the section. And then we will hopefully wrap this up right on 12:30 today. This webinar qualifies for half a CPD point, so please add that to your log. It is just the 30-minute session today if you are collecting those. And as I mentioned, there are questions always welcome in the chat. We do want these to be interactive. So if you need some support or guidance with anything, or you can't locate something and you need some help, by all means, please ask away in our chat. So let's get into our first question of the poll. So the first question we asked was, how confident are you that your quality indicator data accurately reflects the care you deliver? Pretty strong, 66%. So vast majority here are somewhat confident. 23% are very confident, 10% not very confident, and 1% not confident at all. So pretty strong with the 66% of being somewhat confident that it's reflecting there. And as you'll see with some of these other numbers, there's definitely a 20-odd% cohort that obviously are pretty confident on most of the things and how they're monitoring and tracking their indicators. The second question was, how early can you usually see a quality indicator heading in the wrong direction? And again, similar to the previous poll, 56% can see within the reporting quarter, 29% in real time, which is fantastic. Obviously got some good systems and processes in place to be monitoring those numbers and what they're collecting. 13% only once the results are published. And then 1% not until it affects our rating. So hopefully from some of the sessions today, they may be able to pick up on some things and tools that may help them, reverse that trend and maybe get into the 29% bracket where people that are staying on top of them and seeing these in real time. The third question we asked was, how easily can you see how your quality indicators compare to the rest of the sector? So essentially benchmarking and comparing your indicators. So 43% they can see this with some effort. So they obviously go and look at the numbers. 29% only when government data is published. 22% we benchmark in real time. And 6% we can't really see. So again, consistently through those sort of three main things of looking at your information, tracking it, staying on top of it, and then also benchmarking, there's that sort of 20% percentage that sort of holds true across all of those variables. And then lastly, which quality indicator is the hardest for your home to move? So 29% falls and major injury, 27% said restrictive practices, and then equal on 18%, we had medication management and unplanned weight loss, and 8% with pressure injuries. And Tyler's going to dive into some more of these numbers and the trends that we've seen with the quality indicators that will highlight some of these areas and some of those things that are a little bit harder to move, but then also others that over time have reasonably improved through the process. So with that, I would like to hand across to Tyler, and Tyler is going to dive into the latest quality indicator data and what it also says about care outcomes. So Tyler, please take us through these numbers.
Thanks, Ben, and thanks everyone for those answers. They're a good setup for what I want to walk through now. And for the next few minutes, I'm going to take you through what the latest quality indicator data is actually telling us across the 5 areas the polls just touched on. So falls and major injury, pressure injuries, unplanned weight loss, medication management, and restrictive practices. I'll also spend a couple of minutes on how risk adjustment and case mix shape the numbers you see published and how all of this rolls up into your star rating. So let's get into it. This is the full picture here. There are 14 quality indicators published every quarter under the National Aged Care Quality Indicator program, but only 5 of them actually feed into your quality measure rating. So that's really where I want to start. And nationally, in the October to December quarter, pressure injuries sit at 5% of residents, and that's been falling at around 1.3% a quarter. And that's a statistically significant trend. Falls that resulted in major injury are at 1.7%, and that's down 1.8% a quarter. Significant unplanned weight loss is at 8%, which is down 1.5% a quarter. And then on medication management, polypharmacy is at 35% and antipsychotics at 18%. And both of those are trending down. But the one that hasn't moved is restrictive practices. So that's sitting at 22% nationally with no significant change over time. And before I get into each of those in depth, I want to spend a moment on why the department bothers publishing these 5 at all, because it's not arbitrary. Pressure injuries can take months to heal and sometimes never heal completely, and they're linked to a reduced quality of life and increased disability. Falls are the leading cause of unintentional injury in older Australians. Unplanned weight loss is a sign of malnutrition, and malnutrition really touches on every system in the body. It raises the risk of hospital admission. Polypharmacy and antipsychotic use both carry real risk of adverse drug reactions because as we age, our bodies become more sensitive to medication and less able to process it. And restrictive practices, even when they're used with good intent, can cause lasting physical and psychological harm. And that's the thread running through everything I'm about to show you. These aren't just reporting obligations, they're proxies for real harm to real residents. The other 9 indicators are still worth knowing, and that's activities of daily living, incontinence associated with dermatitis, and they've held steady. Hospitalization is the one to watch. Both emergency department presentation and hospital admissions are trending up. On the positive side, workforce turnover is down, and consumer experience and quality of life are both improving. So let's jump into it on the next slide, which should be, yeah, falls, pressure injury, and weight loss. So here's what that picture looks like over time. 4 years of quarterly data, and the direction is consistent. Pressure injuries peaked at around 7% in late 2022 and have come down steadily to 5% today. Falls with major injury have eased slightly over that same period. Significant weight loss is the noisiest of these 3. You can see it spiked to almost 11% in early 2022, but the overall trend line is still heading down, and it's sitting at 8% now, well below that peak. One worth calling out, total falls. It's not shown on this chart, but sitting at around 32% has barely moved in 4 years. So residents aren't falling less often, but fewer of those falls are resulting in serious injury. And that's a meaningful distinction if you're triaging where to focus your falls prevention work. And so now I want to spend a bit more time on why each of these 3 matter clinically, not just statistically, because it changes how you prioritize your improvement work. Start with pressure injuries. A pressure injury is damage to the skin or the tissue underneath it caused by unrelieved pressure, friction, or shearing, and it usually develops over a bony prominence. There are 3 core causes worth knowing. Pressure itself, which is a person's body weight compressing the skin for a period of time, most common in residents with poor mobility who can't shift their own weight. friction, where two surfaces rub together, for example, when someone is pulled across bed linen, and shearing, which is downward pressure or sliding, like when a resident positioned upright in bed slides down. The risk factors to watch for are reduced mobility, moisture from incontinence, poor nutrition, and existing comorbidities. And this is why the more severe stages count for more in your star rating. So stage 4, unstageable and suspected deep tissue injuries carry real risk of amputation, sepsis, and death. And they can take many months to heal, sometimes never fully healing. Falls are next, and they are the leading cause of unintentional injury in older Australians. So this is genuinely one of the highest stakes indicators on the list. Not every fall can be prevented, but the evidence is strong that screening, monitoring, and prevention activity reduces both the frequency and the severity of falls. Older Australians are more vulnerable, partly because of frailty and reduced muscle tone, and partly because of conditions like osteoporosis weaken bones, which is exactly why a fall that might be minor for a young person can result in a fracture or a head injury in one of your residents. Poor nutrition also raises fall risk, which is a nice segue into the third measure on this slide, unplanned weight loss. Nationally, roughly half of aged care residents are either malnourished or at risk of malnutrition. So this is far from a niche issue. Weight loss becomes a quality indicator concern in two ways. Significant loss of 5% or more of body weight over 3 months, or consecutive weight loss of any amount across three straight months. The causes are rarely just one thing. They span social factors like eating alone, physical causes like difficulty chewing or swallowing, psychological factors like low mood or cognitive decline, and care setting factors like limited staff time to support residents at meal times. The reason this matters so much clinically is that malnutrition doesn't just affect appetite, it affects every system in the body. It increases vulnerability to illness, accelerates frailty, drives up complication rates, and increases the risk of both hospital admission and death. So across all three of these, the pattern is similar. Identify the residents at risk early using validated assessment tools, document a clear plan, implement targeted prevention strategies, and reassess regularly. That's the same continuous improvement loop the department describes in the QI program manual, and it applies whether you're tackling pressure injuries, falls, or weight loss. So let's move on to the next slide and look at medication and restrictive practices. So medication use keeps easing across the sector. Polypharmacy has come down from 41% in late 2021 to 35% now. Antipsychotic use has fallen from 22% to 18%. And that's a sustained, statistically significant decline, not just a one-off quarter. Restrictive practices is the outlier on this slide, and it's worth sitting with that for a moment. It's essentially unchanged on a 4-year view. So 23% back in September 2021 versus 22% now. But you look at the shape of that line, it actually fell through 2023 down to the 17 to 18% range and has been climbing back up since. So if your own home trend looks like that U shape, you're not alone, but it's really worth understanding what changed operationally over that period. So let's unpack why each of these matters. Polypharmacy is defined as 9 or more medications prescribed to a resident, and it's a genuinely growing problem. The research shows the number of older Australians regularly taking 5 or more medications rose 52% between 2006 and 2017. And by 2017, more than a third of older Australians were affected. The reason it matters clinically is that as we age, our bodies become more sensitive to medication and less efficient at absorbing, distributing, metabolizing, and eliminating it. And more medications into that mix, the risk of an adverse drug reaction climbs quite sharply. Um, we're taking with that risk, we're talking about falls and fractures, dehydration, functional decline, cognitive impairment, delirium, declining nutrition, drug interactions, and in serious cases, hospitalization or death. That's why a regular medication chart review and escalating concerns to a pharmacist or GP for a residential medication management review is such high value quality improvement work. Antipsychotics are a related but distinct concern. These are medications intended for diagnosed psychosis, but in aged care, they're frequently prescribed off-label to manage behavioral and psychological symptoms of dementia. Research suggests that as many as 42% of residents may be regularly prescribed one. The adverse effects range from relatively minor through to unpleasant, painful, disfiguring, or life-threatening. And the complications depend on the specific drug, the dose, how long someone's been on it, and what else they're taking, and their individual sensitivity. Where an antipsychotic is genuinely being used as chemical restraint, providers need a behavioral support plan in place, which now brings us to restrictive practices. Restrictive practices covers physical restraint, mechanical restraint, environmental restraint and seclusion, but also chemical restraint, which is tracked separately. There's real concern nationally about the overuse of restrictive practices, and the legislation is clear that it should only ever be used as a last resort in the least restrictive form and for the shortest possible time, and only after alternatives have been tried and documented. The reason it carries so much weight is the harm it can cause. Psychologically, that's fear, shame, anxiety, loss of dignity, agitation, depression, and lower cognitive performance. Physically, it ranges from bruising and skin injury through to contractures, reduced mobility, impaired muscle strength and balance, and in the most serious cases, serious injury or death. There have been documented cases of restraint applied for falls prevention, leading to neck compression and asphyxiation. That's precisely why this indicator isn't risk adjusted. The expectation is that its use is minimized full stop, regardless of who you care for. If you're looking to move this number, the department's guidance points to four areas to assess: environmental factors like lighting, noise, and layout, psychosocial factors like familiar staff and meaningful activity, care approach factors like individualized routines and supervision, and physiological factors like medication review, nutrition, hydration, pain, and infection. A lot of agitation that leads to restraint has a treatable underlying cause, and that checklist is a good place to start looking at it. Let's jump now to what I just sort of alluded to, which is the risk adjustment and case mix. So before I move on to any other elements, I just want to explain something that trips a lot of people up when they compare their own numbers to what's published nationally. Three of the five quality measure indicators are risk adjusted before they roll into your star rating. Pressure injuries use a resident's Braden scale scores and their ANAC mobility data. Unplanned weight loss uses ANAC classification and frailty status. Falls and major injury use ANAC mobility data. So in practical terms, the Braden scale is a validated tool that scores a resident across things like mobility, moisture exposure, and nutritional intake, essentially quantifying how vulnerable their skin is before a pressure injury ever develops. And as you know, ANAC is the classification system that already determines your funding and your staff rating. So the mobility and frailty data it captures gets reused here. The effect is that a home with a higher proportion of low mobility, high frailty residents is expected to have a higher raw rate of pressure injuries, weight loss, and falls. And the risk adjustment accounts for that before comparing you to anyone else. On the other hand, restrictive practices and medication management are deliberately not risk adjusted. Restrictive practice use is expected to be minimized regardless of who you care for. And the analysis behind medication management found adjustment wasn't warranted there. So here's the catch. The national trend data I've just shown you and the state and remoteness tables published by the AHW are raw and unadjusted. So if your home looks after a complex high needs population, you'll often show higher raw rates than a lower acuity home down the road, even when your actual care quality is comparable or better. So when you're benchmarking against peers, always reach for your risk-adjusted quality measures rating rather than the raw published figures. So now let's move on to how we then get to the star rating. So how does all of this actually land on your overall star rating? So there's 4 subcategories, and the quality measures carries a 15% weighting, sitting alongside resident experience at 33%, compliance at 30%, and staffing at 22%. Within that 15%, it's the same 5 indicators we've been talking about: pressure injuries, restrictive practices, unplanned weight loss, falls and major injury, and medication management. Stage 1 pressure injuries don't count towards the rating, and the more severe stages, stage 4, unstageable and suspected deep tissue injuries, carry more weight in the calculation. Otherwise, the 5 indicators are weighted equally. It's worth knowing why quality measures sits at the lower end of that weighting, so at 15% against the resident experience at 33%. When the star ratings were designed, the department weighted each subcategory based on 2 things: how important older people and providers said it was, and how mature the underlying data was at the time. So quality indicator data is still a relatively young measurement system compared to something like the annual resident experience survey, which is one reason it carries less weight for now. That doesn't make it less clinically important, which is exactly why we've been spending time on it today. It just means it's one input among several other, rather than being the whole picture unto itself. 2 things worth remembering. First, activities of daily living, incontinence, hospitalization, workforce, consumer experience, and quality of life are all published, but none of them feed the quality measure rating directly. Second, and this catches people out, a compliance rating of 1 or 2 stars caps your overall rating, regardless of how well you're doing on quality measures. So compliance still comes first. All right, let's move to the next slide with my last piece before we can pivot to some questions. So this table gives you a way to pressure test where your home sits against the rest of the sector. For each of the 5 key indicators, you've got the 25th percentile, then the median, and then the 75th percentile across all homes nationally, plus the best and worst performing states. And as a rule of thumb, if you're sitting inside that 25th to 75th percentile band, you're in the middle 50% of Australian homes on that indicator. For the adverse event indicators, so that's falls, pressure injuries, weight loss, restrictive practices, and medication management, being below the 25th percentile is generally the stronger position to be in. And some caution, as before, though, these are raw, unadjusted figures. So weight them alongside your own home's case mix before you draw conclusions. And one last thought before I hand back. Whichever of these five indicators you decide to focus on, the department's own guidance points to the same improvement cycle every time. Plan, do, check, act. So plan using your QI data to understand what's actually driving the number. Do it at a small scale first. Check whether it's working with both the data and staff feedback, and act by embedding it properly if it works, or try something else if it doesn't. And so that's the data for today. I'll hand back for questions now, and yeah, feel free to keep dropping those in the chat.
Fantastic. Thanks so much, Tyler. One quick thing we'll do just before we jump into the questions, just for anyone who's not aware, obviously the department and the commission are always updating resources and providing additional guidance to the industry. So if you're not aware, recently the Star Ratings Provider Manual just went through an update this month, version 2.10. So there is a QR code there which you can grab. Otherwise, you will find these in the department's website through their resource page sections. But the Star Ratings recently had an update. There's also, the home for everything. All the main QI program resources can be found on that second item. And lastly, as well, the department also recently updated and published a number of new interactive modules for the QI program that you can use for educational purposes as well. So 3, 13, 14, and 15, which I think was restrictive practices, and some of the workforce and lifestyle modules also had updates. So, as Ty said, let's dive into some questions. We have had a few in here, Tyler. Now, I'm not sure if you'll be able to answer all of these, but one of the ones I thought was quite interesting was, please expand why some indicators are risk adjusted and some not. Are you aware why that is the case?
Yeah, not much beyond what I've already said, in that there has been research into what warrants case mix adjustments, where frailty and mobility do seem to suggest that as a raw number you're going to have more falls, but yeah, the ones that have been singled out, so restrictive practices, it's just not a solution to behaviors or symptoms. There are underlying causes that can be dealt with and treated, as opposed to going straight to restrictive practices. So that isn't something that warrants case mix adjustment.
Yeah. Fantastic. And there was another question here, but I'm not sure whether this sort of information is published. So what percentage of residents in a facility that highlights an issue with the meal substance rather than the clinical factors, is there a percentage that has been documented? For example, if a facility has 25% of their residents on supplements, would this indicate that there may be an issue with the protein in the meals provided? So I don't know if they break the numbers down further around the difference especially around weight loss.
Not that I'm aware of. I haven't seen any data that tracks use of supplements. That's an interesting question. I know, there's certainly a lot of attention that goes into food, expenditure on food and preparation of food. Yeah, I'll see what I can find there, and potentially get back, but nothing I have been exposed to singles out supplements.
Okay, great. And then there are a couple of comments around restraint, which I was expecting. Obviously, restraint, the definition has been updated over time, obviously, with people. So there are a few comments around, obviously, the environmental restraints, but I don't think it really dives directly into your numbers. And conscious of time, I will keep progressing on, but thank you everyone for those questions. So Mirrors do offer some complimentary star rating reports. So if that is something that you are interested in, again, there is a QR code there. You can also reach out to us via our website if you're interested in having a look at some of your data as well. We also have our Mirrors Metrics application. So if you're one of those percentages in those poll results where you don't have visibility and you can't see things and you would like to be able to see things again, we have a solution that may be able to help you. So please, again, reach out to us and our team, and we may be able to take you through some of your numbers and what you can sort of then start to see as it's trending. Okay, coming up next month, our August webinar, we're diving into the world of recruitment and retention, lessons from inside aged care. So we're going to be having a chat to some providers and some experts in the industry. Workforce obviously is a huge factor in the aged care space. We're all aware that obviously an aging population, we're going to need the workers. How do you recruit and retain and keep those workers? So we will be diving into that in August. So registrations will come out shortly. So pencil it into your diaries, Thursday, the 27th of August at 12 p.m. And also back to a full hour session with that one, because we will have a panel to join us as well. So keep an eye on your inbox for that information. Also, if you would like to share your point of view, if you want to join us at any of these panels and jump on, please drop us a line at our marketing@mirrors.group email address. We'd love to have you on. We'd like to get the insights and the word from all of the providers out there and what you're doing. So please reach out if this is of interest to you as well.
So I can talk less that way.
And then Tyler won't have to present.
If you're not interested in joining a panel, you can nominate someone as well. Tell us who you think should do it.
Yes, but Tyler will always come with his data. But yes, we can definitely have more people, more voices, and that's the forum we like to have on these webinars. So wrapping it up today, hopefully nice and short. We're just over time, but on behalf of myself and Tyler, thank you so much, everyone, for joining us, and we'll see you at the next one in August on Workforce. Thank you so much.
Have a good afternoon.